losses of trabecular meshwork. ठीक है, जो भी हमने ये पढ़ा है ना यहीं पे primary open angle glaucoma, this is what we are reading in detail. What is the presentation, what are the risk factors, how do you treat, what are the problems. Okay, we are reading this topic now in detail. Okay guys, this is our next half an hour discussion. So guys, as I told you, this glaucoma occurs in very old age people, so we should know what are the other risk factors. Okay, what are the other risk factors? So first of all, it's in old age, males, especially who are blacks, they have had a myopia. Okay, so very simple to remember, काला चश्मिश बुढ़ा, है ना, काला चश्मिश बुढ़ा. ठीक है, very simple to remember like that. So old age, males, black, myopes. Next is patients who have a thin cornea. Thin cornea, जिनका cornea भी पतला है, and they have had a high IOP any time in their life. ठीक है, more commonly seen in diabetics and hypertension. Okay, so primary open angle glaucoma is more common. It is more common in diabetics and hypertension. ठीक है, these are the associated factors, not the actual risk factors but the associated factors. ये risk factors नहीं है. Being diabetic is not a risk factor, but in diabetics POAG is found more common. ठीक है, ये समझ में आता है सबको? Okay guys, these are the risk factors. Now what is the presentation? What is the presentation guys? So presentation is unfortunately most of the time asymptomatic. These patients are mostly asymptomatic. That is why we say POAG is a silent killer. बूढ़े बाबा को पता ही नहीं चल रहा क्या हो रहा है आंख में. It is mostly asymptomatic. But sometimes you may have a complaint of repeated change of near vision number, near vision power. What do you mean by that? So you must have seen your grandparents reading newspapers with the chashma, है ना? You must have seen reading with the help of newspapers. Now they can come to you with complaint of repeated change of that near vision number. ठीक है? So that is a very important and a specific complaint. Please remember, it's a very important specific complaint. Is that clear, friends? Okay, guys. So this is repeated change of near vision power. चलो आगे देखते हैं. Now friends, when I see this patient, when they come to us, we see certain signs. First of all, I'll find out the IOP is high. Can I label him to have glaucoma if the IOP is high? Can I say he has a glaucoma? No. I should check something more. I should check the optic nerve. Yes or no? I should check what are the changes at the level of optic nerve. ठीक है? Yes, you should see at least 2 findings from the triad. 2 findings at least. ठीक है ना? So I will see the optic nerve changes. Now friends, before we talk about the changes, we should know what is the normal optic nerve, है ना? पहले हमें normal पता होना चाहिए. What is the normal optic nerve like? So let us see the normal optic nerve. First have a look at the picture and then we'll draw a diagram. ठीक है? First we'll see a normal picture. Now have a look guys to this. So this is the interiors of the eye. This is your retina that is seen by the ophthalmoscope. Okay, so this is a part of the retina which we see by the ophthalmoscope. Now can you see this part? What is it? This is the visible part of the optic nerve. होता क्या है बच्चे, देखिए सभी लोग, होता क्या है देखिए. If this is your eye, this is your optic nerve which is going to the brain, and a part of the optic nerve is visible inside the eye as the optic disc. So this part is what? This is your optic disc. Can you see? This is the part of the optic nerve which we see inside the eye as optic nerve head or the optic disc. ठीक है, इसके पीछे optic nerve नहीं दिख रही है, but at least you can see a visible part of the nerve. Okay, so this is your optic nerve head or the optic disc. ठीक है. Now guys, can you see the central part of the head? This central part of the head is called as the cup. क्या कहते हैं इसको? Cup. Now this part, the peripheral part of the disc, is called as the NRR, the neuroretinal rim. Now again, look at me and try to understand. This optic nerve is mainly made up of the ganglion cells. ठीक है? The ganglion cells are mainly seen in the periphery, in the rim. The central cup is actually a depression. It's like that. This is the central cup, which is a depression, and this is the rim. Are you able to see? So this cup has no ganglion cells. The rim has the ganglion cells. Okay. Normally, we all have a CD ratio, CDR. What is CDR? Cup to disc ratio. Cup to disc ratio. ठीक है? And normally this ratio is approximately 0.3:1. मतलब ये जो कप है ये डिस्क का 1/3 है. Cup is almost 1/3 to the disc. This is normal. Now let's see the right side. What happens when you have high IOP? What happens in glaucoma? There is death of ganglion cells, damage to the ganglion cells. So can you see the rim is thinning out? Rim gets thinned because there's a damage of ganglion cells. In other words, we say the cup is increased, cup is enlarged. So what happens to CDR? CD ratio is also large. Yes, Dr. Priyam is absolutely right. So this is a picture question. You have to identify that increased cup to disc ratio is seen in glaucoma. This is the first sign. Okay, बच्चे, अब हम यही चीजें सब कुछ लिखेंगे. What we have read, we will now draw everything. ठीक है? So optic nerve changes पढ़ने से पहले we should know what is the normal optic nerve. ठीक है? Normal optic nerve. So this nerve is mainly made up of ganglion cells, which are actually present in the NRR. What is NRR? These cells are present in the neuroretinal rim. Am I right? They are present in the neuroretinal rim. Now all of you have a look here. So this is your optic nerve head of the right eye. Right retina. Why right retina? Because I have drawn the optic nerve on the right side. ठीक है? तो ये right side के, left side की कैसे बनाऊंगी? Left side की ऐसे बनाऊंगी. This is for the left side. Am I clear, friends? How to say this is right or this is left? If the optic nerve is on the right side, it is right sided. Okay, if it is on left side, it is left sided. Now first pay attention, I'll give you time to draw. पहले आप समझ लीजिए, ठीक है? So in the center part there is a cup, and this is your NRR. Now when I enlarge only this part, मैंने इसको enlarge कर दिया है, ठीक है? मैं इसको enlarge करूँ. This is your cup. This is your NRR. This has your ganglion cells. ठीक है? Cup does not have ganglion cells. So what about the normal ratio? The cup to disc ratio, the vertical ratio is almost 0.3:1. This is the normal cup to disc ratio. ठीक है? Normal cup to disc ratio. This is 0.3:1. Okay, all of you. Now you can draw. अब आप सब फटाफट ड्रॉ कर लीजिए और जिसको नहीं समझ में आया मुझसे पूछ लीजिए. Dr. Tanisha, have you drawn? Please draw first. Dr. Tanisha and everyone, please draw first. So normally, this is the problem, na, because you did when I was explaining. When I say stop and when I'm explaining, you just see what I'm explaining. Then you understand it better. चलो मैं फिर से बता रही हूँ. Those who have not drawn, those who have drawn, you can listen to this. So normally, optic nerve is a nerve which is starting from the eye going to the brain. You cannot see the whole of the nerve, but a part of the nerve is visible in the retina as the optic nerve head. ठीक है? As the optic nerve head. And we call this particular area, इस पूरे एरिया को क्या नाम दिया है हमने? Disc, which is also called as optic nerve head. Both of them are same. Optic disc is same as optic nerve head. This is same. Okay? Optic nerve head or the disc is the same thing. Right? Now, the disc has a small central cup. and the periphery. This is your central cup. This is the central cup. This is your central cup which has no ganglion cells, and this is your periphery. Okay, this is the periphery. This periphery is NRR which has ganglion cells. So normally the ratio is 0.3:1. But whenever you have high IOP, there is death, damage of ganglion cells. So your NRR will be shrinking. NRR will be shrinking and your cup will seem to be enlarged. So you have large CD ratio. Disc is in NRR or NRR is in the disc, beta? Dr. Deepu, have you understood? बोलो बच्चों. No, Dr. Deepu. Dr. Tanisha, have you understood now? बेटा ये तो बहुत ही सिंपल है. ये डिस्क है, ये कप है, ये पूरा डिस्क है. दिस होल थिंग इज डिस्क. द सेंट्रल पार्ट इज द कप एंड दिस पेरिफेरल पार्ट ऑफ द डिस्क इज NRR. ठीक है, अब ठीक है. चलो, गुड गुड. अब so now you know how the normal optic nerve looks like. ठीक है, now you know what should be the normal. So let us write down everything what can be there in a abnormal nerve. Okay, so I'll show you a chart and a table which you can just copy down, guys. Just a second, where is it? हाँ जी. So I'll just explain you once and then you can write down everything. पहले आप लोग समझ लीजिए बच्चे. So these are all the signs of glaucomatous damage in POAG only. ये प्राइमरी ओपन एंगल की बात हो रही है. ठीक है, सो पहले हमने क्या पढ़ा? नॉर्मल ऐसा होता है. दिस इज द नॉर्मल. सो व्हाट इज द फर्स्ट वन? द कप बिकम्स वर्टिकली ओवल. दिस इज द फर्स्ट चेंज. वर्टिकली ओवल कप. ठीक है, वर्टिकल. Now what about the cup to disc ratio? The cup becomes so large, so large, so large, so large that the cup to disc ratio is almost 0.7:1. More than 0.7:1. Cup is getting enlarged. ठीक है. Now the next is you see a hemorrhage on the disc. Hemorrhage on the disc. So this is your hemorrhage. Now rest of the signs you need not to understand, but you have to learn, and this is the mnemonic which helps you. H1N1 lab 3. Now in कोरोना वी हैव फॉरगॉटन H1N1, है ना. हम तो H1N1 को भूल गए हैं. तो H1N1 क्या है? H1 is hemorrhage, N1 is notching. What is lab 3? Laminar dot sign, asymmetry, and 3 B's are bayoneting, bearing, and beam pot cup. So you have to copy down very quickly. So these are all questions. Simply they'll ask you, notching of the disc is seen in which case? Notching of the disc, hemorrhage of the disc is seen where? ठीक है, ऐसे सिंपल क्वेश्चंस पूछ लेते हैं. एंड माइंड यू, अ वर्टिकली ओवल कप इज अ इम्पॉर्टेंट साइन. अ वर्टिकली ओवल कप इज मोर इम्पॉर्टेंट एज अ साइन. ठीक है बच्चे, ये सब आपको लर्न करना है. बहुत ही सिंपल है, कुछ भी मुश्किल नहीं है. रिमेंबर H1N1 lab 3. What is L? Laminar dot sign. 3 B's are bayoneting, bearing, and beam pot. Bayoneting, bearing, and beam pot. ठीक है. So this is the second thing which we have checked in the patient. The IOP was high. The optic nerve has either of the changes or many of the changes. The third thing which we are going to check is the visual field effects. ठीक है, अब हम तीसरी चीज क्या पढ़ेंगे? विजुअल फील्ड में क्या प्रॉब्लम हो सकते हैं. That is what we are going to read now. चलो, सो अब पहले हम समझते हैं. लुक एट मी गाइज टू अंडरस्टैंड फर्स्ट. So when I close my left eye, whatever I see from my right eye is my right visual field, isn't it? Whatever I see is my field. When I close my right eye, whatever I see from my left eye is my left visual field. You must be knowing that the nasal field, the medial field are common, है ना? यहाँ का इससे भी दिखता है, यहाँ का इससे भी दिखता है. So the nasal fields are common. Yes or no? Okay. Now guys, we all have a small area where we have a blind spot. Blind spot means अगर कोई छोटा सा चीज वहां आ जाए तो हमें दिखेगा नहीं. We all have a small area as a blind spot in our field. ठीक है? Because we have an online class, so I can't demonstrate how to check the field, how to check that blind spot. But please try to understand थोड़ा सा कि blind spot generally day to day life में हमें problem क्यों नहीं करता. It's because the blind spot lies in the nasal field. Okay, so this eye blind spot will be covered by the field of the other eye. This eye blind spot will be covered by the area of field of the other eye. Okay, so we have a small area blind spot which is normal for all of us. Now the question, why exactly do we have a blind spot? Why? So guys, the reason for that is that देखिए सब लोग, so you know the image is formed at the retina, isn't it? The image is formed at the retina. Now the area where your optic nerve head is, this is the area which forms the blind spot in the field. Why? Because this area has no rods and cones. Photoreceptors are not present here. जहाँ ये रेटिना में है, तो अगर यहाँ पे लाइट पड़ेगी तो इस एरिया पे कोई इमेज नहीं बनेगी. क्यों नहीं बनेगी? क्योंकि यहाँ पे फोटोरिसेप्टर्स है ही नहीं. बाकी सब जगह पे आपके रेटिना के अंदर फोटोरिसेप्टर्स हैं, बट जहाँ पे ऑप्टिक डिस्क है वहाँ फोटोरिसेप्टर्स है ही नहीं. So you can't see anything when the image is being formed at rods and cones, because actually no image can be formed here. Okay guys, so this blind spot corresponds to the area of optic nerve head or the optic disc. Okay, this is the first thing. Now how to check the field? So this is by an instrument called as perimeter. What is perimeter? Perimeter is an instrument, it's a machine by which you check the visual field of an individual. ठीक है, अब इसमें हमने क्या किया है, पेशेंट ऐसे रख के चिन और माथा रख के बैठा है. वी शो हिम अ वाइट बैकग्राउंड. इस मशीन के अंदर एक वाइट कलर का बाउल है. ठीक है, पेशेंट का एक आंख बंद किया है. यू हैव क्लोज्ड वन आई ऑफ द पेशेंट. यू हैव गिवन ट्रिगर टू द पेशेंट्स हैंड. ओके, नाउ when the patient is looking in the white bowl, you show stimulus one by one every second in the field. आप बार बार पेशेंट को स्टिमुलस दिखाओगे, यहाँ 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 हर जगह. ठीक है, अगर पेशेंट का फील्ड नॉर्मल है तो पेशेंट ट्रिगर को दबाएगा. इफ द पेशेंट हैज अ नॉर्मल फील्ड ही विल प्रेस द ट्रिगर. बट सपोज इफ द पेशेंट हैज प्रॉब्लम्स इन द विजुअल फील्ड बिकॉज ऑफ ग्लॉकोमा और बिकॉज ऑफ एनी रीजन, ही वोंट सी द स्टिमुलस, सो ही विल नॉट क्लिक द बटन. समझ आ रहा है? अगर उसने बटन नहीं दबाया तो क्या होगा? जब आप प्रिंट आउट निकालोगे, व्हेन यू टेक आउट द प्रिंट आउट, यू विल सी excessive black dots. Please appreciate, all of you, this is the printout of the glaucoma patient. Can you see excessive black areas here? दिख रहे हैं black areas? These are abnormal. Let us see what is a normal field. So this is the normal field. No extra black spots. All of you able to appreciate? ठीक है, this is your normal field. But what is abnormal field? When you see excessive black areas, extra black areas means that you have scotomas. Scotoma means the areas which are not visible. ठीक है, सपोज मैं आपके पास आ रही हूँ डॉक्टर के पास, मैं बोलूँ डॉक्टर साहब मुझे नीचे का दिखाई नहीं दे रहा क्योंकि मेरे को नीचे स्कोटोमा है. If I complain that I can't see the inferior field, that means I have a problem in the inferior field. What is that problem? Scotoma. Okay, are you able to understand a little? थोड़ा समझ में आ रहा है? So before we started glaucoma, I showed you a picture. In glaucoma, the central vision remains, but the field is gone. So gradually in glaucoma, there is a constriction of field. Constriction. ठीक है? So कैसे हो रहा है ये अब हम ये देखेंगे. How things are happening? Let us see that. Okay, let us see that. So this is the third change. You can please write down visual field changes. Visual field changes. ठीक है? This is the visual field changes. The third thing, the third finding. Now guys, I am not drawing the visual field. I am drawing, I'm not drawing the retina, I am drawing the visual field. So this is the visual field of right side, and this black area is actually the blind spot, which is normally present in all of us. Why? Because of the optic disc. Okay? Because of the optic disc. Disc has no rods and cones. That is why we have a physiological blind spot in everybody. ठीक है? ये normal है. ये normal है हम सब में. This is a normal thing. Now what is abnormal, guys? What is abnormal? Let us draw. So again, I want you to pay attention. Don't write. Just give me 2 minutes to explain. Everyone. That's a humble request. Please don't write anything. Just let me explain first. ठीक है? फिर मैं आपको लिखने का टाइम दूंगी. पहले आप सिर्फ देख के समझो. So this is the normal visual field of anybody, the right eye. ठीक है? So first change which occurs in the eye of glaucoma patient is a slight constriction of the field. Field थोड़ा छोटा हो गया है. We call this term to be isoptric contraction. There is a little constriction of the field. थोड़ा छोटा हो गया है. तो ये किसी को पता नहीं चलता. It goes unnoticed. That is why we say glaucoma is a silent killer. Patient को पता ही नहीं चला क्या हो गया, है ना? The second change is blind spot area gets excluded. That means ये वाला field चला गया. ये nasal area चला गया. So if I'm talking about the right eye, this field is also gone. What is left with you now, guys? What is left with you? This part is the only left out area. ये जो part है ना, सिर्फ ये बचा है आपका. बाकी सब चला गया है. ठीक है? Exclusion of the field. Now, what is the next change, guys? Next change is the formation of a wing-shaped paracentral scotoma. This is the third change. Wing-shaped paracentral scotoma. ठीक है? This is the first identifiable change. Patient आके बताता है, डॉक्टर साहब मुझे ऊपर का हिस्सा या नीचे का हिस्सा नहीं दिख रहा है. This is the first change. ठीक है? Now gradually what is happening? Let me draw. Do not draw as of now. मुझे बनाने दो पहले, आप कुछ नहीं करना. ठीक है? What is the next one? The damage is increasing, so these two join each other. And what is now the shape? What is now the shape? This is a sickle-shaped scotoma. What is now the change? This is a sickle-shaped scotoma. ठीक है? तो देखिए क्या बन जाएगा? We call it a sickle-shaped सीडल स्कोटोमा. कैसे बनाइए सीडल स्कोटोमा? ब्लाइंड स्पॉट जॉइंस द पैरासेंट्रल. ठीक है? अब क्या होएगा देखिए, डैमेज इज फर्दर इंक्रीजिंग, सो इट एक्सटेंड्स ऑन दिस साइड एंड नाउ दिस बिकम्स अ आर्क शेप स्कोटोमा. ये पूरा आर्क बन गया है ना, एक आर्क. सो वी कॉल दिस स्कोटोमा टू बी आर्कुएट स्कोटोमा. दिस इज आर्क शेप स्कोटोमा, आर्क शेप. व्हाट हैपेंस नेक्स्ट? इट बिकम्स अ रिंग. So this is a double arcuate scotoma, ring shape. कैसे होएगा देखिए, अब ये बढ़ के यहाँ तक पहुंच गया है. Please see, ये बढ़ के यहाँ तक पहुंच गया. This is a ring shape scotoma. So what has happened in the end? Everything is gone. You are just remaining with the central tunnel vision. Okay? This is happening. Tunnel vision बन जाती है. हाँ जी, are you able to understand, guys? थोड़ा समझ में आ रहा है? Double arcuate or ring scotoma, in the end we are left with the tunnel vision. The central vision is left. Okay? So now you can draw, guys. Now you can write down and you can draw. ठीक है? Outer purple area, see, it is you know, main जो glaucoma में defects होते हैं ना, they occur in the paracentral region. Paracentral. It is called as a Jerum's area. ठीक है? It is called as a Jerum's area. Main is our this field, है ना, ये है ना. इसके ऊपर का तो मैं am not much interested. Yes or no? It is the main, the central 30 degree which I am mainly interested. ठीक है? Which one do you want, Shriya? This one? बाद में दिखाती हूँ, पहले आप ये ड्रॉ कर लो. Let others also write. Okay? Let others also write. Quickly write down and make a diagram, guys, all of you. I'll show you the first one also quickly. ठीक है, आप लिख लो. I'll draw the diagram again. जो भी समझ में आ रहा है अभी लिख लो. I'll draw the diagram again. Okay. The first one is isopteric contraction. Second is blind spot excluded. Third is wing-shaped paracentral scotoma. Wing-shaped paracentral scotoma. The fourth one is sickle-shaped sedal scotoma. Next is like the shape of the arc. It is an arcuate scotoma. Arcuate scotoma. उसके बाद है द डबल आर्कुएट और द रिंग स्कोटोमा. डबल आर्कुएट और द रिंग स्कोटोमा. ठीक है. अब रिंग स्कोटोमा को क्या नाम दिए हमने? टनल विजन, बिकॉज इट इज द सेंट्रल विजन विच इज नाउ ओनली रिमेनिंग विद द पेशेंट. नाउ अ वेरी फेवरेट क्वेश्चन ऑफ एग्जामिनर इज अबाउट द टनल विजन. Is there any other condition where you have tunnel vision apart from TOAG? Yes, this is retinitis pigmentosa. So in retinitis pigmentosa, guys, also we see central tunnel vision. Rest everything is gone. Okay? So again, I'm saying this is a very important question. Tunnel vision can be seen in two types of pathologies. One is POAG, another one is this retinitis pigmentosa. You just finish writing, then I'll write down. I'll make the diagram again once more so that you learn it now. अभी तो आप नोट्स बना लो फटाफट, फिर आप समझ के लर्न कर लेना. When you are done, please tell me. Yes, Dr. Palak, sickle shape is when paracentral join the blind spot. ठीक है, मैं फिर से समझा रही हूँ, सारा कुछ देख लीजिए. Somebody who wish to write down from the first slot, this is the first one. ठीक है, डॉक्टर वाघेला का हो गया. चलो अब देखिए, एवरी आई ऑन द बोर्ड, सभी लोग देखिए ऑन द स्क्रीन. So this is the normal blind spot for everybody. ठीक है. The first change which we see in primary open angle glaucoma patient is कि field थोड़ा सा छोटा हो गया. This is called as isopteric contraction. जो मेरी writing समझ में नहीं आया था, isopteric contraction. This is the first change. Isopteric छोटा हो गया, थोड़ा सा छोटा. ठीक है. The second change is that this area is now gone. ये जो नेजल एरिया, अगर मैं इसकी बात करूं फील्ड की, द नेजल एरिया इज ऑल्सो गॉन. वेयर योर ब्लाइंड स्पॉट इज, दैट एरिया इज ऑल्सो गॉन. ठीक है, ये चला गया. अब क्या बचा ये, फिर क्या होगा? नाउ द नेक्स्ट चेंज इज दैट यू सी अ पैरासेंट्रल विंग शेप्ड स्कोटोमा. विंग शेप्ड स्कोटोमा इन द रिमेनिंग फील्ड. Now next is the defects are increasing. So these two join each other, blind spot and this one will join each other. Yes, ये पूरा ज्वाइन हो गया आपस में. ये क्या बन गया? सिकल शेप सीडल स्कोटोमा. द नेक्स्ट वन इज दैट these comes down, all of them, so it becomes a large defect, a arc shape. It is an arcuate. Now the field defects are further increasing. It comes on to the other side also. This becomes a double arcuate scotoma. So what is left? just the central vision, the tunnel vision. ठीक है? Now, yes. Blind spot will always be, blind spot is actually a scotoma. Dr. Priyam, blind spot is a scotoma only. It is a scotoma only. Blind spot is not covered, it is actually a scotoma only. ठीक है? Now you have to learn one very very important feature. Please write down. Please write down. Sometimes central tunnel is also gone. Sometimes central tunnel is also gone. But a temporal island of vision, a temporal island of small field is persisting till the end. Now, what do you mean by that? Retinitis pigmentosa, Dr. Shubham. Retinitis pigmentosa. Tunnel vision is left, मतलब कि small central vision is left, but rest everything is gone. ऐसे करके देखो, आप खुद से अपने आप पता चलेगा. Can you live a life with that? A small central tunnel vision. You can't go down the stairs. You can't cross the road. You can't see anything. अब सिर्फ इतना दिख रहा है तो मुझे नीचे दिख ही नहीं रहा ना क्या है. I can have injuries. Yes or no? My field is gone. Field कितना जरूरी है, आप मिस नहीं करते यार. पीछे भी आंखें होती तो कितना बढ़िया होता है ना. हमें यहाँ तक है, पीछे होती तो और क्या मस्त मजा आ जाता. ठीक है ना. अब यहाँ क्या है, अब सिर्फ इतनी रह गई. So it's hard, it's very hard to live like that. Okay, now you understood what is tunnel vision, Dr. Palak. चलो, मैं कह रही हूँ कि कभी कभी ये सेंट्रल भी चली जाती है तो क्या बचता है इनमें. जस्ट लुक एट मी. Just a temporal small island, this much, very small temporal island. Okay, so what is the question here? Which field can be persisting till the end? So the answer is temporal field. Okay, temporal. Please remember this particular statement. It's very very important. The temporal island can persist till the end. It can persist till the end. Okay, this you have to learn. चलो ओपन एंगल पे कुछ क्वेश्चंस कर लें, है ना. लेट्स डू सम क्वेश्चंस ऑन ओपन एंगल सो दैट whatever we have done so far we can quickly revise. Let's see if you have understood something or not. ठीक है, चलो देखो. फर्स्ट क्वेश्चन बताइए. आई वांट एवरीबॉडी शुड आंसर. सभी बच्चे आंसर बताएंगे, सभी लोग. whosoever is there in the class, all of you. It's a simple one. Very good. Good बच्चे, good. So what is the name of this tonometer? It is a Chiod tonometer. It is a touch wala technique and it is indenting the cornea. Very good. Good. Now again, try to attempt this question. ठीक है, it's a very good question. I'm just enlarging is which field defect is this? Try to see. ठीक है. Now I'm showing you the choices. What type of field defect is this, guys? It's very interesting one. It is an expected question this year. बहुत बढ़िया, बहुत बढ़िया. डॉक्टर मोदी, नो इट्स नॉट. सी द ऑप्शंस ना बेटा, ऑप्शंस देखो. डॉक्टर मोदी, ऑप्शंस देख के बता बच्चे क्या आएगी. इट इज अ इंफीरियर आर्कुएट स्कोटोमा. वेरी गुड, इंप्रेसिव, गुड. अब समझ में आ रहा है सबको? ठीक है, सबको समझ में आया है ना. इट्स अ इंफीरियर आर्कुएट स्कोटोमा. सो दीज आर योर एक्सपेक्टेड क्वेश्चंस. ओके, ये देखिए. So which sign is more important in an open angle glaucoma? Think about it. What is more important? I told you the hint, vertical cupping. Very good. So a vertically oval cup is very important. You remember the first statement, the cup becomes oval and then the enlargement. Okay? Okay, it is very important as a sign. The vertical cupping is very important. Good, 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 good. Dr. Rahul को बिल्कुल confirm है. ये बताइए all of you. डॉक्टर मोदी, आप बताओ इसका आंसर. सिकल शेप्ड एक्सटेंशन. वेरी नाइस. इट इज योर सीडल स्कोटोमा. ठीक है, सिकल शेप एक्सटेंशन, इट इज योर सीडल स्कोटोमा. गुड गुड गुड. ये बताइए. सो दिस इज अ लिटिल ट्रिकी वन. लेट्स सी इफ यू कैन आंसर. ट्रिकी है, थोड़ा सा ट्रिकी है. देखो, थोड़ा ट्रिकी है ये. देखो, बताओ. गलत, डॉक्टर सिद्धेश्वर का गलत। और बताओ, सो दिस इज रॉन्ग। वेरी गुड, गुड। चलो मैं आंसर बता रही हूँ, आई एम गिविंग यू एन एक्सप्लेनेशन, ठीक है? प्लीज सी, I told you there's a classical triad of high IOP, visual field damage, or optic nerve damage. I want either of the two things, minimum, ठीक है? Now, what is the definition of this? High IOP with a normal optic nerve. What is the definition? ये क्या में फिट हो रहा है? ये किस चीज में फिट हो रहा है? ना बेटा, नहीं, एनटीजी में थोड़ी हो रहा है हाई आईओपी। ये फिट हो रहा है ऑक्यूलर हाइपरटेंशन में, यस और नो? इट इज फिटिंग इन द ऑक्यूलर हाइपरटेंशन का डेफिनेशन है ना। हाई आईओपी है बट नर्व नॉर्मल है, सो व्हाट इज फिटिंग विद दिस? दिस इज योर एनटीजी। नैरो एंगल तो होएगा ही नहीं, वी आर टॉकिंग अबाउट ओपन एंगल, सो नैरो एंगल तो बिल्कुल भी नहीं है। ओके, agree, convinced all of you? I told you this is a little tricky one. इतना मुश्किल नहीं था but थोड़ा tricky था, so this is your correct answer. Agree all of you? So such questions can be there in your exam, okay? Please remember the definition of ocular hypertension and what is NTG. We have everything which is fitting into some or the other definition. The best option is the C option, ठीक है? डॉक्टर मोदी, मैं तुम्हारा क्वेश्चन नहीं समझी बच्चे। इट्स नॉट नॉर्मल मैम, मैं आपका क्वेश्चन नहीं समझी हूँ डॉक्टर कलगी मोदी। डॉक्टर मूर्ति, even I haven't understood your question also. Please write down the complete question. मेरे को नहीं समझ में आया क्वेश्चन। See, okay, Dr. Modi, it's not important. You will read different types of glaucomas later when tomorrow we'll read something where you have a optic nerve damage and visual field changes, ठीक है? You will read. Your pressure may be normal, ठीक है? We have not mentioned about IOP here. I'm telling you this is the best option available for chronic simple glaucoma. Even then I have not mentioned about IOP, but this still seems to be the best one, ठीक है? Dr. Modi, what is the definition of ocular hypertension? High IOP with a normal optic nerve with a normal field. Think simple. चलो ये बताइए, देखो again it's an interesting one. What is not seen in open angle glaucoma? What is not seen in open angle glaucoma? Not seen. What is the definition of open angle glaucoma? That the angle should be open. So, yes, anterior chamber. Why anterior chamber will be shallow, beta? Open angle का क्या definition है ना? So this B is the answer. अभी हम closed angle पढ़ेंगे तो ज्यादा अच्छा समझ में आएगा. I'll show you, ठीक है? चलो ये बताइए, ये बताओ, what is the normal ratio? What is the normal ratio? ओए आदित्य, A क्यों बोला? Below 0.2 क्या होता है? 0.2 is 0.1. Do you think 0.1 is normal? Do you think 0.1 is normal? Dr. Aditya, नहीं ना? So below 0.5 is the best option. ठीक है? Below 0.2 means 0.1, which should not be normal. वो बहुत छोटा हो जाएगा बच्चे. ठीक है? Below 0.5 means 0.4, which is also normal. Okay? ठीक है? हाँ, good. चलो, so guys, I'm hoping, I'm expecting that you are able to solve at least 60 or 70% of the questions in the class. Yes or no? 60-70% हो पा रहे हैं? I hope that you've understood the concept here. POAG is a different thing. Now we'll be talking about PACG, primary angle closure. ये जो primary open angle है, इसको एक दिमाग में बिठा लो, ठीक है? And just keep it there because we want to read something very different, which is primary angle closure, ठीक है? Sedal scotoma का picture I don't have, and I'm sure they won't ask you. If at all they give you a perimetry picture, Dr. Ishwarya, if at all they give you a perimetry picture, it will be very easy. because it is the first time they are going to ask you. If at all they ask you, they'll show you very simple, बहुत ही easy पूछेंगे. तो सीडल पीडल को मत याद करो, just remember the arcuate ones. ठीक है? Yes, Dr. Muhammad, it is a variant. It is a variant of primary open angle glaucoma. Yes. Okay? Dr. Modi, don't get disappointed. बच्चे ये तो सबके साथ हो रहा है. We are all in the same boat. मैं भी आपके जैसी हूँ, कोई बात नहीं. सबके साथ होता है. But the important thing is that at least you should attempt. आपकी तरफ से देखो कमी नहीं होनी चाहिए, है ना? आप attempt तो करो. आज गलत हो रहा है, कल गलत होगा, बट एक दिन ठीक भी होगा, होगा ना? बट अगर हम आज ही नहीं करेंगे, कल भी नहीं करेंगे, तो फिर वो कब आएगा? ठीक है? So it's with everyone. See, reading theory, learning the points, cramming the points is one thing. But when it comes to solving the questions, अंडा हो जाता है सबका, है ना? It happens with everyone. Not only you, it happens with everyone, all of us. So the best thing is that you read the theory, make some concepts and apply that knowledge in your MCQs. Simultaneously, you must solve the MCQs. So if next time I'm going to ask this question or a question similar to this, I'm sure Dr. Aditya will not be wrong. है ना Dr. Aditya? Because you have attempt and you were wrong. तो इस टाइम अब अगली बार गलत नहीं करेगा, है ना? होता है ना ऐसा? बट आज आपने क्वेश्चन ही नहीं करे, आप सीधा एग्जाम में देखोगे तो गड़बड़ होनी ही है फिर तो. इसीलिए कहते हैं प्रैक्टिस करना है. अगर आज मैं आपको ब्रीफ ओवरव्यू देती हूँ. आई एम जस्ट गिविंग यू अ ब्रीफ ओवरव्यू. देयर आर हंड्रेड्स ऑफ क्वेश्चंस इन ग्लाकोमा. वी आर डूइंग 25-30 क्वेश्चंस, बट व्हाट इफ यू डोंट डू द रेस्ट ऑफ द क्वेश्चंस? अब आपका काम शुरू होता है. ठीक है? आपका काम शुरू होएगा. अब शुरू तो करो, तब तो खत्म होएगा बच्चे. ठीक है? शाम का टाइम है ना, आफ्टर 5 o'clock यू हैव टू स्टडी. वटेवर यू रीड, आपने आज जो नोट्स बनाए, फटाफट नोट्स पढ़ोगे और फिर साथ में क्वेश्चंस मार्क करोगे. वटेवर सोर्स यू हैव, वटेवर, नो नीड टू बाय सम न्यू थिंग्स. अपना फटाफट उसी सोर्स के साथ आप पढ़ते चले जाओ. ठीक है? डॉक्टर प्रियम, अबे यार कहाँ, हम बाकी बच्चों की कहाँ बात कर रहे हो तुम? चलो आओ अब क्लोज्ड एंगल के बारे में बात करते हैं. सो वी हैव कवर्ड व्हाट इज ओपन एंगल. नाउ लेट्स टॉक अबाउट द क्लोज्ड एंगल. ये गाइस क्लोज्ड एंगल जो होता है ना, ये हर किसी को नहीं हो सकता. सो इवन you know, people who are myopes, they can never have the closed angle attack. Why? Because there are certain risk factors. Because there are certain risk factors. What is PACG? Primary angle closure glaucoma. ठीक है? Primary angle closure glaucoma. So there are certain different kind of risk factors. उसमें हमने पढ़ा था कि बूढ़ा आदमी myopia. यहाँ it's totally opposite. How? Because this happens in people who are mainly the hypermetropes. There it was myopia. People who have a small eye. I told you छोटी आंख hypermetropia, बड़ी आंख myopia. So small eye hypermetropia. Patients who also have a small cornea. छोटी आंख, छोटा cornea. ठीक है? You have a shallow anterior chamber. Shallow anterior chamber. And mostly these are seen in females as compared to males. ठीक है? बिल्कुल उल्टा. Females, hypermetropes, a small eye, a crowded eye. These are the risk factors. Now, what are the precipitating factors? Can any female have this? Even I am a middle-aged female. I am having a little hypermetropia. So can I also have, or there are some precipitating factors? So this is the most important thing, guys. Whenever you have a mid-dilated pupil, in such kind of risk factors, mid-dilated pupil, which is brought about by mid-dilated pupil. कैसे कैसे हो सकता है बच्चे? When you give atropine like drugs. कैसे कैसे प्यूपिल डायलेट हो सकता है? जब आप डार्कनेस में जाते हो या फिर आप बहुत इमोशनल हो रखे हो, है ना, इमोशनल हो रखे हो, खुश हो, दुखी हो, टेंस हो, या आप अंधेरे में हो, या आपने एट्रोपिन की तरह ड्रग्स डाले हुए हैं. सो दीज आर योर रिस्क फैक्टर्स, द प्रेसिपिटेटिंग फैक्टर्स विच कैन प्रोड्यूस अ मिड डायलेटेड प्यूपिल. ओके, ठीक है. नाउ दिस हैपेंस बेस्ट व्हेन यू आर इन थिएटर्स, मूवी हॉल्स. ठीक है, आप अपने कलीग्स के साथ, फ्रेंड्स, गर्लफ्रेंड्स, बॉयफ्रेंड्स के साथ गए, है ना, और डार्कनेस में हो, इमोशनल हो, and your pupil gets stuck in the mid dilated pupillary position. Now let us see and understand how this attack develops. ठीक है, पहले देखते हैं इसको, then we'll write something more. Now this time focus on the right side of the picture. All of you please pay attention, all of you. So guys, whenever your pupil is mid dilated in position, this is a risk factor वाला patient का आंख. This is the eye of a hypermetrop. ठीक है. So what happens? Your eyeball is small, your cornea is small, so there is a crowding in the eye. This is a structures crowding. ठीक है. So whenever you have mid dilated pupillary position, just check that the iris and lens are touching each other. Can you see? There is a touch of iris and lens. ठीक है. Earlier it is not there. देखिए, normally it is not there. Normally it is not there. It is open. But here there is a touch of iris and lens. There is a touch. So aqueous is not able to go from the posterior chamber through the pupil. So what will happen? It will get stuck. कहाँ stuck हो गया है? It will remain in the posterior chamber itself. Now when it remains in the posterior chamber, it is going to accumulate here and then it will push the iris forwards. ये iris को धक्का मारेगा. अब जब ये iris को push करेगा तो what will happen? The angle will get closed. Can you see? Because it is pushing the iris towards the cornea, it is going to cause the angle obstruction. Is it okay? So this is a vicious cycle. First there is a pupillary block, then the aqueous gets collected, it pushes the iris towards the angle, and then the angle closes. So it's an acute disease. It's an acute onset. There's a sudden rise of IOP from say 20 to even 60 millimeters of mercury. There's a sudden rise of IOP. Okay. So similar thing happened to this female who went to see a movie. अब क्या हुआ? She is a middle-aged female. She went to see the movie with her boyfriend. फिर क्या हुआ? अंधेरा, emotionally she was high. So what happened? She developed an attack after an hour of the movie. Her IOP rose very high. ठीक है? So what happened? She said, I'm having a lot of pain, I'm having a lot of headache, I can't see anything, I'm going back home and I am sleeping. So she went home, she slept. So what happens to pupil in sleep? Tell me. What happens to pupil in sleep? Batao, what happens to pupil in sleep? When you sleep, meiosis. Please see your chart yesterday what you have made. Meiosis and midriasis. Sleep में meiosis होता है. Sleep में meiosis. Pupil constricts. Not dilated, constricts. मरने के बाद होता maximum dilatation. Coma, death. Dr. Priyam. ठीक है? Coma when you die. ठीक है? So when the patient slept, there is a small pupil. So when the pupil is small, what happened? The block which was there at the pupil is relieved. वापस से aqueous चला जाएगा और ठीक हो जाएगा. So when she got up after 2 hours of sleep, her pain was reduced. She felt normal. ठीक है? But this was happening repeatedly. So this time she developed adhesions, and this is the time when she had sinus. So she came to us with clinical features. So what are the clinical features? Please write down. Again, you will have PVR symptoms. What are PVR symptoms? Pain, decrease in vision, a red eye. PVR symptoms. Okay? You also have a lot of headache, which is radiating to jaw. Jaw pain is also a feature. Severe headache, jaw pain. You can also have nausea and vomiting because of very high IOP. Okay? Because of very high IOP, you can have these features. That is why patient is coming to you. Sudden rise of IOP. Now this is the most important thing What are the different signs? So what are the signs, guys? So I will see the patient has a edema of the cornea. Cornea is hazy. Corneal edema is present. Cornea is hazy. Cornea is not clear. That is why the vision is dropping. Cornea has edema. What else? I will find out that there is a lot of redness in the eye. The next thing is very important, rather the most important thing is the pupil. Pupil कैसा दिखता है in cases में? This pupil is vertically oval, mid-dilated and fixed. Fixed means it is a non-reacting pupil. Fixed means it is a non-reacting pupil. तो मैंने टॉर्च मारी, मैंने देखा ओए प्यूपिल तो डायलेटेड पड़ा है, मिड डायलेटेड पड़ा है, and it is not reacting. What do you mean by non-reacting? Normally when I show a torch of light, the pupil constricts. But here the pupil is not reacting, pupil is fixed. So this is the most important finding. Pupil is fixed. It is vertically oval, mid dilated and fixed. Very, very important. What next? आप IOP में क्या एक्सपेक्ट करते हो? IOP is very, very high, up to 60 millimeters of mercury, and this eye is called as stony hard eyeball. जब आप आई बॉल को ऐसे टच करोगे तो ऐसा लगेगा यू आर टचिंग द स्टोन. इट्स एज हार्ड एज अ स्टोन. Okay, because of the very high IOP. So there are no perimetry changes, no optic nerve changes, because it's an acute condition. Okay, it's a very acute condition. It can happen only in 1 hour also. It's an acute condition. हाँ जी, समझ में आ रहा है कुछ? So POAG and PACG are entirely different. POAG is a chronic condition, chronic, age related. Here, this is an acute condition. Guys, are you able to understand? ठीक है? चलो, good. Now you finish writing, then we'll discuss how to treat. So guys, that patient is coming to me with a lot of pain, lot of headache. He's crying, yelling in pain. So my first treatment, Dr. Mohammed, give me some time. I'll come back to Sinake. I'm coming back to Sinake. Just give me 2-3 minutes more. Can any condition be affected? There can be a family history. Yes, in glaucomas you can have family history, both in open angle and closed angle. Family history you can write down. I missed that point. You can have a family history in open angle and in closed angle both. Okay? Presence of family history can be there here or in open angle both. Dr. Palak, yes. A positive family history can be there in both. Sorry, I missed that point. Hanji. So my aim for the treatment is, first of all, I want to reduce the pressure. If I don't reduce the pressure, there will be a permanent damage. There will be a permanent damage of ganglion cells of the optic nerve. So I have to reduce the pressure first. So how will I reduce the pressure? Because the pressure is very, very high. So this is how I do the management. So first of all, I'm explaining, then I'll give you time to write. पहले आप समझ लो, ठीक है? पहले आप समझ लो. So the first drug to be given question is mannitol. Mannitol is given in the form of injection in a bottle. ठीक है? IV bottle चढ़ा देते हैं mannitol का. It is a systemically acting drug, so it will help in reduction of the IOP very quickly. ठीक है? You can also add glycerol 6 teaspoonful. 6 teaspoonful आप ग्लिसरॉल पिला सकते हो, स्पेशली इफ द पेशेंट इज नॉन डायबिटिक. ठीक है, नॉन डायबिटिक, स्पेशली इफ द पेशेंट इज नॉन डायबिटिक. नाउ आफ्टर दैट you can also give 2 tablets of acetazolamide stat, 2 tablets together. Afterwards the patient will be very happy because the pressure is reduced down from 60 to almost 25 or 30. Patient is happy. But this is the time when I cannot discharge the patient. Now my pupil is still in the mid dilated position, so I will put pilocarpine drops because it is a cholinergic agent, so it will constrict the pupil. Now when the pupil is constricted, it will break the attack. That is why this pilocarpine is a drug of choice. समझ आ रहा है? Because it is going to break the attack. Pupil जब तक छोटा नहीं होगा तब तक कैसे बात बनेगी, ठीक है? अब हम क्या करेंगे? We will do a gonioscopy. Gonioscopy to plan the further treatment. We should do some definitive treatment, yes or no? So when you do gonioscopy, you will see how much synapse are there, how much adhesions are there. So if the adhesions are minimal, if the adhesions are very less, very minimal, what will you do? Please understand. देखिए, मैंने कहा कि यहाँ ब्लॉक हो जाता है, यहाँ ब्लॉक हो जाता है, तो ब्लॉक हो रहा है तो होने दो. If there is a block, let it happen. I create a new passage for aqueous to drain. This is the new passage of drainage of aqueous. ठीक है? How I created this passage? This passage is created by use of laser. We have made a hole in the peripheral part of the iris. Can you see? This is a picture question. So I have created a hole in the peripheral part of the iris through a laser. What is the name of the laser? ND-AG laser. A question. मैंने क्या किया? एक नया रास्ता बना दिया. भाड़ में जाए, अगर हो रहा है ब्लॉक तो होने दो. हमने नया रास्ता बना दिया, ठीक है? But this opening will not help if you have adhesions everywhere. If you have adhesions everywhere in the angle, this opening will not help. Aqueous यहाँ से तो चला गया, but यहाँ अटक जाएगा. If you have lot of adhesions around, lot of synapse around, this opening will not help. And in that case, you have to do a definitive surgery. This definitive surgery is called as trabeculectomy. So if you have high number of synapse, you have to do a trabeculectomy surgery. What is this surgery? Ectomy matlab cutting. So what do you do here? It is a surgery basically. So you are cutting a part of trabecular meshwork. You cut a part of trabecular meshwork itself. पूरा का पूरा एंगल में नहीं काटते, छोटे से एरिया में trabecular meshwork को काट दो. So there is a normal drainage of aqueous throughout the life. Is that understood, friends? So this is the whole algorithm. Now you can write down. And there are 3 questions. Quickly write down. Please write down. Dr. Harjot, it can damage the optic nerve even in the first attack if you don't treat it quickly. If you don't treat it quickly, na, if you don't reduce the pressure, then definitely the nerve can be damaged permanently. You have to treat the pressure quickly. Dr. Priyam, we can't start with pilocarpine because any topical drop won't act if you have a very high pressure. सबसे पहले आपको प्रेशर कम करना पड़ेगा, तभी टॉपिकल ड्रॉप्स की एब्जॉर्प्शन होती है, अदरवाइज टॉपिकल दवाइयां काम ही नहीं करती. Similarly, in case of corneal ulcer, if you have a glaucoma, also first treat the glaucoma. If you don't reduce the pressure, the topical antibiotics also will not act. ठीक है? तो प्रेशर पहले थोड़ा कम होएगा, तब आप पाइलोकार्पिन शुरू करोगे. ठीक है डॉक्टर प्रियम? It's a good question. I always expect somebody should ask this question in classes. बहुत कम बच्चे पूछते हैं. Good. Trabeculectomy अभी बताऊंगी, पहले आप लिख लो. ठीक है? First write down. I'll explain what is trabeculectomy again. First finish writing. There are 4 questions from this topic, from this chart. My question number 1, which is the first drug to be given? Which is the first drug to be given? The first drug to be given is mannitol. Question number 2, what is the drug of choice? Pilocarpine. What is the drug of choice? Pilo is the drug of choice. Question number 3, what is the treatment of choice? Treatment of choice is PI, peripheral iridotomy. Now my question, 4th question is why both eyes? पेशेंट कह रहे डॉक्टर साहब यहाँ दर्द तो यहाँ हुआ है, आप इसमें क्यों छेद बना रहे हो? अटैक तो यहाँ आया है, आप इसमें क्यों छेद बना रहे हो? मेरी आइरिस में छेद क्यों बना रहे हो? है ना? What will be your answer? Why are you making hole here? So the answer is it is a prophylactic procedure here. Prophylaxis. Very good, Dr. Alex. It's a prophylaxis. That patient is an anatomically predisposed patient. So this eye will be similar to the other eye, isn't it? If patient is diabetic, then also you have to give mannitol the first. Dr. Bhuvanesh, अगर पेशेंट डायबिटिक है तो भी मैनिटॉल देंगे, मैनिटॉल में डायबिटिक से कुछ नहीं है, ग्लिसरॉल नहीं देना है फिर, है ना। अगर डायबिटिक है तो ग्लिसरॉल नहीं देना है बेटा। चलो आगे देखिए, आजकल वो जमाना नहीं है डॉक्टर सूर्या, मैं डॉक्टर हूं तू नहीं। आजकल सब गूगल डॉक्टर्स हैं, गूगल पेशेंट्स हैं, यू नो, एवरीबॉडी everybody comes with the knowledge of Google. So you can't say, you can't challenge this to patients कि डॉक्टर मैं हूं तुम नहीं, they know everything. चलो ये लिख लिया। Dr. Palak, we have not missed because that is the last topic which I take, the drugs. All the drugs together I will take. Dr. Palak, I'll take all the drugs together. Now here is your question, बच्चे ये पूछते हैं। In 2000, I think 2019, नहीं 2018, you had a question. Peripheral iridotomy, which lasers are used? So NDAC, the same laser which was used for capsulotomy, the same laser. Okay, this time they can give you a picture question. ऐसी पिक्चर देंगे, पूछेंगे ये ओपनिंग कौन सी है, विच ओपनिंग इज दिस, सो दिस इज अ पेरिफेरल iridotomy opening, which lasers, NDAG lasers, a picture question. Okay, it's a picture question as well. Now please write down this. ये लिख लीजिए, trabeculectomy, when trabeculectomy is done, when PAS is peripheral anterior synechiae. So when synechiae are more, you have to do the surgery. So what is trabeculectomy? In trabeculectomy, we are cutting a small part of trabecular meshwork. See angle 360 degree होता है, पूरे एंगल में ट्रेबिकुलर मेशवर्क है, बट आप एक छोटा सा पार्ट ट्रेबिकुलर मेशवर्क का काटते हो सुपीरियरली. So you cut a very small part of trabecular meshwork from the superior part of the limbus. Okay, so if you have cut, what will happen? The aqueous will not be obstructed. There will be a continuous drainage of aqueous directly to the subconjunctival space. Okay, so there is never a hampering of drainage of aqueous. This is your trabeculectomy. Okay, so this is what is trabeculectomy. अब समझ में आ रहा है थोड़ा सा? Now I'll show you a picture question regarding the treatment of primary angle closure glaucoma. ठीक है, अब मैं आपको एक पिक्चर दिखाऊंगी. So पढ़िए. Expected question. So what is the first drug to be given for this patient who has pain and redness with a headache? So again you have pain, red eye, and you can see the cornea is hazy, isn't it? Cornea is hazy. So what is the characteristic thing here? The pupil. The pupil. What can you see in the pupil? The pupil is fixed and mid-dilated. Yes. So what is this picture? This is a picture of primary angle closure glaucoma. So how will you treat? What is the first drug? The first drug has to be mannitol. ठीक है? That is how you have to identify. It is the pupil which gives you the diagnosis. If you have a dilated pupil, it has to be a glaucoma, angle closure glaucoma. ठीक है? I'll show you tomorrow how uveitis patient looks like with the same presentation. The same presentation can be there in uveitis, but in uveitis the pupil will be small and irregular. Okay, it is the pupil which gives you the diagnosis many a times. ठीक है बच्चे? So this is your angle closure glaucoma. See the mid-dilated pupil, see the edema in the cornea. Okay, a very important question. चलो ये बताओ, देखिए you have understood something or not. What is false? What is not correct? Very good. So pilocarpine is never the first drug to be given. Okay. Initial choice is mannitol, laser iridotomy is done, and peripheral iridotomy helps when synechiae are less. Good. Chalo, ye batao. Yesterday we have read this. Let's see if you remember something from yesterday's topic. Dr. Ronak is very quick in answering. Very good. बहुत बढ़िया. Good. So glaucoma flecken is a type of a complicated cataract which is after angle closure glaucoma. Very good. Good. बढ़िया. चलो ये बताइए एक बार. So guys, we have read primary open angle, we have read angle closure. The next topic for us is, the next mechanism for us is congenital glaucoma. Okay? This is the next mechanism for us, congenital glaucoma. Please write down. The problem in congenital glaucoma is neither a open angle nor a closed angle. So what is the problem? We say that there is a trabeculodysgenesis. We say there is a trabeculodysgenesis. The meaning of the word dysgenesis is malformed, not properly formed. That means trabecular meshwork is malformed. Trabecular meshwork ठीक से बना ही नहीं है. Trabecular meshwork is not properly formed. Okay. So if trabecular meshwork is not properly formed, will it be able to drain the aqueous efficiently? No. Okay. So what are the different types of congenital glaucoma? The first one is a true congenital, which is present at the birth. The baby is born with a with a congenital glaucoma. The baby is born with a. Are you able to hear, friends? भैया ये कुछ गड़बड़ हो गया है शायद. कुछ गड़बड़ हो गया, देखिए एक बार. कुछ तो हुआ है. क्या अपने आप ही हुआ, पता नहीं. वो कुछ लिखा नहीं आ रहा. मैं लिख रही हूँ पर वो दिखा नहीं रहा. ये नहीं हो रहा. रिकनेक्ट हो रहा है ना. ये भी नहीं चल रहा. इंटरनेट तो आ रहा है ना. नेट नहीं चल रहा. देखता हूँ पीछे से. मेरा फोन दीजिएगा. मैं ये फोन. देखो रिकनेक्ट करके. हाँ हो गया. आ गया ना. हाँ. नेट का कुछ. नेट का ऐसे. Can you see and hear me? Is that okay, friends? Yes. So we were on the congenital glaucoma. I am telling you that congenital glaucoma is of three types. First is a true congenital, where the baby is born with a glaucoma. Infantile is which is not at birth but within 3 years of birth. Okay, which is not present at birth, but if the baby develops a glaucoma within 3 years, you will say it is infantile. The third type is juvenile. Juvenile means which is after 3 years and which is till 16 years. Okay. Now, if they ask you which is the most common one, then infantile is the most common variety. This is the most common type. Infantile type is the most common type. Okay, बच्चे, there are three types of congenital glaucoma. Now, what is the classical picture? This is the most important question. These children have a classical triad, and this is called as BPL, below poverty line. Below poverty line. This is a mnemonic just to learn, okay? Below poverty line, it's just a mnemonic to learn. These children are below poverty line, not economically but socially. Socially. What is the classical triad? Let us see, friends. What is the classical triad? It is blepharospasm. Blepharospasm. P is photophobia. Photophobia. And what is L? Lacrimation. Watering from a neonate's eye. Lacrimation. The mother comes to your clinic with a baby, small baby in her lap, and she says, "Doctor, my baby doesn't open the eye. He closes the eye, blepharospasm. He closes the eye forcefully, blepharospasm. Whenever the baby opens the eye, he again tries to close. There is photophobia. And then there's a watering from the eye, lacrimation. Okay, there is a lacrimation, there is a watering from the baby's eye. So this is a classical triad of the symptoms of the baby. Okay, now what will you see? What will you see? What are the signs? So first of all, you see that the eyeball is large. All the things in the eyeball are large. The cornea is large. Cornea is not only large, but it is also hazy. Because of the enlargement of all the things, it appears as if this is the eye of a bull. We call this eye to be bull's eye. Okay? We call this eye to be a ophthalmic eye. Bull's eye, ophthalmos. ठीक है? Cornea बड़ा हो जाता है, cornea hazy हो जाता है, the eyeball also gets large. So it looks very similar to the eye of a bull. Now देखिए बच्चे, this is your typical bull's eye. So what is the similarity of this eye, a bull's eye, with the eye of a congenital glaucoma? Have a look here into this eye. So what do you see here? We see that the cornea is so large that hardly any sclera is visible. Yes or no? Cornea इतना बड़ा हो गया है कि sclera तो दिख ही नहीं रहा है. Sclera is hardly seen. This is the eye of a bull, ophthalmic eye. So this is a picture question, friends. Very, very important. I'm sure you will be able to answer. Okay? A small child comes to you with watering, photophobia, and you see a large cornea. Please think about congenital glaucoma, the bull's eye. Dr. Bhuvanesh, the third point is lacrimation. Lacrimation, watering from the eye. Lacrimation. Chalo. So apart from that, what else would you see, guys? The lens is also large. Lens is large, lens is flat, and you see classically half stripe. Half stripe. What are half stripe? So in keratoconus we saw lobed stripe. Here we have half stripe. So these are horizontal. These are horizontal stress lines. Those were vertical stress lines. These are horizontal stress lines at Descemet's membrane. Again, very simple to remember, H and H. Those were V, lobed stripe, vertical. Guys, unfortunately, we don't have much treatment for these people. We just have to do surgery. There are two types of surgeries which are described. First is goniotomy. Another one is a combination procedure where we cut a part of trabecular meshwork, trabeculectomy, plus we are opening the rest of the trabecular meshwork. This is called as trabeculotomy. So this is a combination procedure and this is the best described procedure. Okay, you can do either, but this is the best one. So again, so many questions on congenital glaucoma. You should remember the clinical picture, the classical triad, what are Harp's triad, and what are the surgeries. The anterior chamber will be deep, yes, because these patients have a large eyeball. So all the things which we have in myopia, large eyeball, large cornea, deep anterior chamber, large lens. Okay. Now guys, let's talk about all the drugs together. Let's discuss what are the drugs. So guys, any anti-glaucoma drug would act in either way or a combination of ways. Like we want the IOP should go down. So this can be first, either the production is reduced or you increase the drainage, either trabecular drainage or uveoscleral drainage. है ना? So any anti-glaucoma drug will give you either of these mechanisms. Okay. No Rishabh, no Dr. Rishabh, no picture of Harp's try here. I don't have any picture and it is not required also. So the first class of drug which we are reading is PG analogs, prostaglandin analogs. And prostaglandin analogs acts by increasing the uveoscleral outflow. Very commonly asked question. They act by increasing the uveoscleral outflow. So they reduce the IOP. These are the best drugs. Why? Because there is a maximum reduction of IOP. They decrease the IOP the max. These are best drugs. So can anybody tell me any example of these drugs? All the drugs which have prost in the end. Latanoprost, bimatoprost, okay, travoprost, etc. Okay, etc. Latanoprost, bimatoprost, travoprost, etc. Okay. Now, what are the side effects? This is the most important question, friends. What is the side effect? Most important question. Do you know what is the job of prostaglandins in our body? Do you know what is the job? What does prostaglandin do in your body? These are inflammatory mediators. Prostaglandins are inflammatory mediators. And when you give prostaglandin in the form of a drop, what will happen in the eye? There will be inflammation in the eye. Simple. बॉडी में इन्फ्लेमेशन कर रहे हैं तो आप बाहर से दे रहे हो रेटिना आंख में, तो आंख में भी इन्फ्लेमेशन होगी. सिंपल. सो हाउ डज इट प्रेजेंट्स? Redness and itching because of the inflammation. These are the most common side effects. Most common redness and itching. Do not get confused with the hypertrichosis thing. Hypertrichosis thing. What is hypertrichosis? There is a lash growth. It is a very specific side effect which is used cosmetically worldwide by females and patients who have lost their eyelashes after chemotherapy or anything. लड़कियां यहाँ पे ऐसे ड्रॉप्स लगाती हैं लेटानोप्रोस्ट की ताकि they have the lash growth. Okay, but this is not something which I would do because it is associated with another side effect, that is pigmentation. I never want dark circles. Do you want dark circles? Do you want dark circles? So though you can have big eyelashes, thick bushy eyelashes, but lid pigmentation can be there. Apart from that, you can have change in the color of iris also. Because you have edema in the retina, you can also get a cystoid macular edema. This is the most important question. Cystoid macular edema. You can have inflammation in the retina as well. Okay? But please remember, the most common is redness and itching. Most common is redness and itching. So the next class of drug is beta blockers. Percentage of drug is not required. Not required. At least if you want to remember, you can remember about letanoprost. It is 0.005%. Otherwise, it is not required. Okay, it's not required. The next class of drug which we have to study is beta blockers. So what is the mechanism of action, guys? They decrease the production of aqueous. They decrease the production of aqueous. Okay, what are the examples? Anyone? You can give timolol and you can give betoxolol. Okay, betoxolol. So which one is a non-specific here? Which is a non-specific? Timolol is a non-specific one. So it has effects related to your heart problems like bradycardias हो सकते हैं, cardiac slowing, cardiac arrhythmias. You know the side effects of beta blockers, है ना, better than me. And you can have bronchospasm, COPD, bronchospasm. That is why these drugs are contraindicated in people who have heart troubles and respiratory problems. You can't give timolol. Betoxolol can be given safely. Okay? It's a specific one, so you can give that, but not timolol. They are contraindicated. Now, one very, very important question is the ocular side effect. It is dry eye. When you put timolol, you can have dry eye. So it's a very important side effect of timolol. Now guys, इसका कतई मतलब नहीं है कि आपने एक ड्रॉप टिमोलॉल की डाली और भगवान को प्यारा हो गया बाबा. No, it's not like that. It's a chronic use of the drug. Okay, gradually it slows down your heart rate. Okay friends, it's not that one single drop of timolol can lead to a bradycardia and arrhythmias and patient can die. No, it's a chronic use, long term use. Okay. Okay. The third class of drug is alpha agonist. Alpha agonists work by two mechanisms. First, they decrease the production and they increase the uveoscleral outflow also. Okay, they increase the uveoscleral outflow also. There are two mechanisms of actions. Now, anyone, any example? So you have brimonidine, apraclonidine, brimonidine and apraclonidine. Okay. Now guys, one of the very important and frequently asked question is about the side effects of brimonidine. So brimonidine and other alpha agonists, they have the power that they can cross the blood-brain barrier. So if they can cross the blood-brain barrier, they can cause CNS depression, especially in children. Especially in children. That is why this is the drug which is contraindicated in young children. Okay? This is the drug which is contraindicated in young children. Very frequently this question is asked. But please remember, brimonidine is the only drug which is safe in pregnancy. Okay? It is the only anti-glaucoma drug which can be safely given to pregnant females. Okay, it is brimonidine. Now the next class of drug is carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. As the name suggests, carbonic anhydrase inhibitor. So it inhibits carbonic anhydrase enzyme and it decreases the production of aqueous. Okay, it decreases the production of aqueous. So any example of this drug? Any example? Acetazolamide. Then dorzolamide. Dorzolamide. What next? Brinzolamide. Brinzolamide. Okay? Acetazolamide, dorzolamide and brinzolamide. Acetazolamide, dorzolamide, brinzolamide. Now, important question. This is the only orally given drug. The only orally given drug. ठीक है, एसिटाजोलामाइड का ड्रॉप्स नहीं आता है, सिर्फ ओरली खाते हैं, गोली खाते हैं. ठीक है. Now side effects are again very very important guys, very important question. Side effects of acetazolamide. So the first one is gastritis. The most important one is आपका पेट खराब हो जाता है, पेट खराब हो जाएगा. You will have metallic taste in mouth. It tastes very very bad. But it is a very good drug when you are traveling to Leh Ladakh. कोई गया है कभी? अगर आपने देखा होगा तो वहां पे माउंटेन सिकनेस हो जाती है, तो उससे पहले लोग एसिटाजोलामाइड की गोली खा लेते हैं. इट प्रिवेंट्स माउंटेन सिकनेस. ओके, अदरवाइज इट्स अ गुड ड्रग. नाउ अदर साइड इफेक्ट्स आर दैट यू कैन हैव tingling sensation. tingling sensation. ठीक है. डॉक्टर भुवनेश ने लिया है. हैव यू एवर ट्राइड एसिटाजोलामाइड? Gastritis, metallic taste, tingling. Now important side effects are metabolic acidosis, some dangerous side effects. Metabolic acidosis. What else? You can have renal stones. Renal stones. You can have renal stones. मुझे नहीं पता. CNS depression is a side effect of alpha agonist. Contraindication is children. You cannot give this drug in children. CNS depression is a side effect of this drug. That is why it is contraindicated in children. ठीक है. Cardiac overload. These are all mentioned in your pharma book also. Overload. Cardiac overload, cardiac failure. And this is one drug which is contraindicated when you have a sulfa allergy. I hope you know that this is a sulfa group of drug. So it is contraindicated when you have a sulfa allergy. ठीक है. The next new class of drug is Rho kinase inhibitor. It's a new class of drug. Rho kinase inhibitor. ठीक है. It's a new drug. So Nitar Sudil. Sudil जहाँ पे आपको मिले, Sudil. Nitar Sudil. These Sudils are your Rho kinase inhibitor. What is their mechanism of action? They increases the trabecular meshwork outflow. They increases the trabecular outflow. Okay. At least remember this name, Nitar-Sudil, Rho kinase inhibitor. It increases the TM outflow. Please remember at least this much about the new drug. All right, friends. ठीक है. चलो. Now something mentioned about the secondary glaucomas. First one is pigmentary glaucoma. Pigmentary glaucoma. So we'll read only this one, pigmentary glaucoma, because there can be some questions. They have never asked you, but they can ask you pigmentary glaucomas. Now what is the meaning of this word pigmentary? Pigmentary का क्या मतलब हुआ? Something related to the pigments, which is the pigmented area of the eye. Which part of the eye has pigments? The iris, है ना? Iris has pigments, isn't it? So some kind of pigments are accumulated in the angle because it's a secondary glaucoma. If you remember what was secondary, there is accumulation of abnormal things in the angle. So what can happen in pigmentary glaucoma? Pigment which are released from the iris can go and block the angle. ठीक है? Very simple. So pigmentary glaucoma, first of all, is seen in individuals who are rather young, males, and who have a myopia, especially when they do exercises. Young male myopes when they do exercises. So what can happen, guys? whenever they are doing exercises, only in few people, not every young male myope, people who have a predisposition, and whenever this young male myope is doing exercise, there is rubbing of iris with the zonules and the lens. They are very close to each other, yes or no? So there is rubbing of the iris with the lens and zonule. So what will happen? The pigments will come out, and these pigments will be liberated, and they get and deposited within the angle. They go and gets deposited within the angle. So what will happen? A rise of IOP. Not only in the angle, but pigments can go and gets accumulated at various places. Yes or no? पिगमेंट्स निकले हैं तो वो और भी कहीं जमा हो सकते हैं. जरूरी थोड़ी है सिर्फ एंगल में जमा होंगे. जरूरी थोड़ी है वो सिर्फ एंगल में जमा होंगे. दे कैन गो एनीवेयर. दे कैन गो टू द कॉर्निया, दे कैन गो टू द लेंस, दे कैन गो टू द जोन्यूल्स, दे कैन गो एनीवेयर. So these are the manifestations. So what do you see? You will see a Krukenberg spindle. You can see a Krukenberg spindle, which is pigments on the endothelium of the cornea. Pigments on endothelium of the cornea. पिगमेंट्स आइरिस से निकले हैं तो वो ना सिर्फ एंगल में जा रहे हैं, ग्लोकोमा कर रहे हैं, बट वो और जगह भी जा रहे हैं. सो दीज पिगमेंट्स कैन गो टू द कॉर्नियल एंडोथेलियम आल्सो. एम आई क्लियर? सो Krukenberg spindle is a question. What else do you see? You can see a Sempowles's line. Sempowles's line. Sempowles's line. Okay, what is Sempowles's line? You have to learn this, guys. This Sempowles's line is a pigmented Schwalbe's line. Pigmented Schwalbe's line. So again, this is a question. Where do you iris? अब ये होते क्या है देखिए, जहां जहां से आइरिस में से पिगमेंट्स निकल गए हैं वहां पे डिफेक्ट बन गया है. जहां जहां से आइरिस में पिगमेंट्स निकल गए हैं वहां वहां पे डिफेक्ट बन गया. वी कॉल इट द ट्रांस इल्यूमिनेशन डिफेक्ट्स. Okay guys, so these three things you have to remember: Krukenberg spindle, Sempowles's lines, and transillumination defects. See, this is your transillumination defect. जो रेड रेड दिख रहे हैं ना, यहाँ से आपके पिगमेंट्स निकल चुके हैं. So you see defects in the iris. These are transillumination defects, and this is your typical Krukenberg spindle. This is spindle shaped Krukenberg spindle, spindle shape. This is nothing but the pigments which are accumulated, which are deposited on the back of the cornea. ठीक है, Krukenberg spindle. Am I clear guys? ये समझ में आता है सबको? चलो जरा इसका ये देखो. Please answer this question. Answer this question, friends. Are you here? What do you mean by the term heterochromia? Different color of the iris, you remember? So color of the iris will be given by PG analogs. The answer is latanoprost. Important question. Okay, it can change the color of the iris. So anti-glaucoma drug which can be given safely in pregnancy, it is brimonidine. है ना, अभी पढ़ा है ना हमने? No. So which anti-glaucoma medication can cause drowsiness? Drowsiness is by brimonidine. So this is again alpha agonist. No, Dr. Patel, this is, yes, this is C. Dr. Anuj, Drowsiness, CNS depression, drowsiness, brimonidine is the answer. Alpha agonist. Okay, all of you clear? Chalo. So we end glaucoma here. Any questions, any doubt? We are done with drugs, the three mechanisms. We have read the important glaucomas, the picture questions. Any doubt here? So POAG is entirely different from PACG. POAG is painless. P is primary. No, angle closure can be secondary also. That we'll read in uvea. uvea में आपको पढ़ाऊंगी, ठीक है, uveitis में. Both the type of glaucomas can be primary, can be secondary. Primary is different. Secondary is when something does it for you. किसी और की वजह से होगा. That will be secondary. Okay. Cornea verticillata is a broomstick-like pattern which is accumulated on cornea. Cornea verticillata is when you have drugs, when you use the drugs for a long period of time, especially chloroquine, busulfan, they get amiodarone, they get accumulated on the cornea in a broomstick-like pattern. This is your cornea verticillata. Okay? Cornea verticillata. Drugs get accumulated on the cornea like amiodarone, chloroquine, busulfan. They can accumulate. Anything else? So I think few more minutes are left before the end of the session. Now we can start with vitreous and retina, and in between we can take a break. Okay? Chalo, retina padhte hain guys. So first of all, you have to tell me what is the color of retina. ये रेटिना का कलर क्या है? अगर आप रेटिना देखते हो तो it looks something like this, isn't it? It looks something like this. So what is the color of retina? This is my first question. हाँ जी, anyone? What is the color? बताओ, what is the color? Okay, Dr. Ishwarya says it is transparent. Is she correct? Does it look transparent? She's absolutely right. Though the color is transparent, but it appears reddish and orangish to everyone. Why? It appears reddish because behind retina you have a vascular choroid. So listen to this very carefully. This is an inside view. You are looking the retina from inside. Okay? Suppose this is your transparent layer, and just behind this you have choroid which is red. So when you see from inside, this transparent thing will also appear red. So what we can say is that retina is actually transparent, but it appears red or orange due to vascular choroid behind it. उसके पीछे vascular choroid है, ठीक है ना? That is why it appears red. Okay, this is the reason. Now what about the blood vessels? What about the main blood supply to the retina? It is by the central retinal artery, mainly by the central retinal artery. Central retinal artery, guys, it is a branch of what? Central retinal artery is a branch of ophthalmic artery, which in turn is a branch of internal carotid artery. I hope you remember. So internal carotid, ophthalmic and central retinal artery. Okay? Now please understand, retina has got dual blood supply. The central retinal artery supplies only the inner 6 layers. Central retinal artery is only supplying the inner 6 layers of retina. The outer 4 layers of the retina are supplied by the choroidal artery. रेटिना के बाहर choroid है ना, तो वहीं पे choroid की जो artery है वो बाहर की layers को supply करती है. Okay? So retina basically has 10 layers. The outer 4 are supplied by choroid. Inner 6 layers are supplied by the retinal artery. What is that artery? The central retinal artery. So this is your blood supply of the retina. Okay? Now let us study that interiors of eye. Let us study that diagram again. Please see, all of you. Please see. First let us understand and then we'll draw everything. So which eye retina is this? Which eye? कौन सी आंख का retina है ये? Right or left? It is the right eye. Why? Because the optic disc is on the right side. Am I clear? because the optic disc I've made is on the right side. So please understand, this part of the retina is the nasal part. This is the nasal part and this part is your temporal part. ठीक है, ये जो part है ये temporal part है. This whole area is the temporal area, blue. The black is the nasal area. So disc is always on the nasal side. Nasal मतलब यहाँ, temporal मतलब यहाँ. Okay, ये clear है? Nasal retina, the temporal retina. Okay, clear? Now the next thing. So the first question from this slide is, what is the diameter of the optic disc? So guys, this diameter is approximately 1.5. Okay, we'll draw everything, don't worry. We'll draw. Now when I take the center of the optic disc and I draw two imaginary optic discs. Can you see? So this part will be my fovea centralis. So they ask you where is fovea located. So I say 2 disc diameter temporal to the center of the disc. Temporal है ना ये, temporal, this is the temporal part. So 2 disc diameter temporal to the optic disc. Okay, why fovea is important? Because it forms the sharpest image, है ना? Why? Because the cones are maximum at fovea. ठीक है? Similarly, when I take the center of the optic disc and I draw an imaginary circle which is like 5 millimeters in diameter, this whole area will be called as the macula. Now, what is the importance of macula itself? Macula is responsible for the central vision. Optic nerve is responsible for the whole field of vision. That is why in glaucoma, the field was lost, but the central vision was persisting. Am I clear? यहाँ तक सबको clear होता है? Please let me know if you are okay with this or not. So this is your right-sided retina, the nasal area, and this is the temporal area. Okay? What is the diameter of the optic disc? It is approximately 1.5 millimeters. Now when I take the center of the disc and I draw two imaginary discs, this point will be my fovea. And the diameter of fovea itself is similar to the optic disc. This is also 1.5 millimeters. ये भी disc के जितना ही है. So what is the location of the fovea? It is 2 disc diameter. Please write down. 2 disc diameter temporal to center of the disc. ठीक है? It is 2 disc diameter temporal to the center of the optic disc. Okay, friends? Now, I told you what is the importance of fovea. The importance is sharpest image is formed at the fovea. Why sharpest image? Because it has maximum number of cones. This has maximum number of cones. Now friends, I told you retina has 10 layers, but fovea is a very special region because it is also very thin. It is a depression. It does not have 10 layers. Yes, I'm showing you the diagram. Please see, all of you guys. He's my baby who's telling me about how much television he has seen. So he's coming and telling me that. सुन लिया आपने? So guys, look at this picture. Retina has 10 layers. है ना? Retina has 10 layers, and if you see the fovea is a depression. Fovea does not have all the layers. It's a very thin region of retina. But what is the thinnest part of retina? Can anybody tell me? What is the thinnest part of retina? No. Ora serrata is the thinnest part, yes. So I want to show you from this figure that though fovea is a very thin region, it is a depressed area. It does not have 10 layers, but don't get confused, ora is still the thinnest. ठीक है? आप देख रहे हो फोविया में ये गैंग्लियन सेल लेयर है ही नहीं. Please remember this very important fact. Ganglion cell layer is completely absent in fovea. Okay. Now let's come back to this diagram. With what do you want, bache? This one. So this was the importance of fovea, which I want to discuss. Okay. Sharpest image is formed at fovea. Why? Because it has maximum number of cones. It is a very thin region. It does not have all 10 layers. Okay. That is what we have learned so far. Now, if we take the center of the fovea and draw a imaginary area which is 5.5 millimeters in diameter. So this whole area will be called as the macula. The whole area will be called as the macula. ठीक है, ये पूरा area macula है. और macula का क्या importance है? That this is responsible for your central vision. Am I correct? This is responsible for your central vision. Okay. Everybody clear till this point? So you can locate where is optic disc, you can locate where is fovea, where is macula. सबको समझ में आ गया है? These are some questions you should know. Now again, coming to the basic things. Let us come back to our basic things. Let us talk about the artery and the vein also. देखिए सभी लोग, बहुत ही important diagram है ये. This is gonna be a very important diagram. Please understand. Look at this, guys. So this is your central retinal artery, which is coming from your ophthalmic artery, which is further coming from your internal carotid artery. First, pay attention and then you can draw. So central retinal artery is taking pure blood in this direction, giving pure blood in this direction to the retina. Yes or no? It gives pure blood coming from the heart, spreading it to the retina. But you know, the artery and veins in the body are traveling together. But what about the direction of blood flow? It is opposite, always opposite. है ना? Vein carries impure blood, take it to the heart. Artery carry good blood, take it to the organs. So let us draw how the veins are situated. Please see, all of you. So these are the tributaries of the vein, which take impure blood from the retina like that and forms the central retinal vein. If you know the diagram, then only you will understand central retinal artery occlusion, central retinal venous occlusion. Otherwise, you won't understand. ये diagram अपने दिमाग में fit कर लो, ठीक है? It's a basic diagram. What is the direction of blood flow? Everyone clear? Is this image clear to you? Everyone, ठीक है? The arteries and veins are together, but the direction of blood flow is opposite. This will help when we talk about CRAO and CRVO. This will help later. Okay, chalo, let's now talk about the different 10 layers. Now look at this picture and then I'll give you time to draw. First understand. So the inner 9 layers of retina are kind of united with each other. This inner 9 layer collectively is called as NSR, न्यूरोसेंसरी रेटिना. ठीक है, इसका क्या नाम दिया है? न्यूरोसेंसरी रेटिना. Now these 9 layers are separated by the outermost layer itself with a space. There is a gap. And this is called as RPE. What is RPE? Retinal pigment epithelium. This is the outermost layer. Retinal pigment epithelium. Here we will have choroid and here we have the vitreous. Here we have choroid and here we have vitreous. ठीक है? I hope this much is clear. So retina has 10 layers. The outer layer, which is towards choroid, is separated by a gap from the inner 9 layers. Inner 9 layers together collectively is called as the neurosensory retina. ठीक है, यहाँ तक क्लियर है सबको? चलिए, now we will be writing the names of the layers, each layer. कौन सा part? Which part? Dr. Gautam, you have to tell me again. This part? This part you want? Which the last one? The arteries and the veins, or this one? This one or the arteries and the veins? Vitreous. So see vitreous. See, outside we have sclera, we have choroid, we have retina, and then we have vitreous. Yes, vitreous, retina, choroid, sclera. So retina has 10 layers. See, retina itself has 10 layers. The outermost layer, is separated by a gap. This is the gap. Here we have choroid on the outer side. Here we have vitreous inside. These are the 10 layers of retina. Now is it clear? The inner 9 layers together collectively are called as neurosensory retina, and this one is called as the retinal pigment epithelium. Now is it clear, Dr. Gautam? There is a small gap in between the inner 9 layers and the outermost layer. Okay? These are the 9 layers, 10 layers, guys. You have to quickly write down. आप लिख लीजिए, please. I am not expecting you to learn the name of the layers sequentially, but the importance of few layers we will discuss when we talk about the pathologies. When we talk about the pathologies, we'll discuss them one by one. The first layer which is in contact, the innermost layer of retina, is what? Internal limiting membrane. We call it ILM, internal limiting membrane. ILM. Internal limiting membrane, ILM. Next one is nerve fiber layer, NFL. Next is GCL, the ganglion cell layer. Then it is IPL, then it is INL, फिर outer शुरू हो जाते हैं OPL and ONL. Then we have external limiting membrane, and then we have photoreceptors, and then retinal pigment epithelium. Okay, so the importance of few layers will be discussed when we talk about few pathologies. Done? Okay, done guys? चल हो गया सबका? Chalo, before we leave for the lunch break, let us start talking about retinal detachment. Now, guys, detachment. This detachment word is actually a misnomer. Retina, देखिए अगर simply suppose if this is your retina, here you have the vitreous, here you have the choroid. In retinal detachment, it is not detaching from the choroid or from the vitreous. No, it is actually a separation within the retina itself. That is why we say retinal detachment word is a misnomer. So what exactly happens? Let me show you with the diagram. Please see. All of you please see. This is your neurosensory retina, the inner 9 layers. This is your RPE, the outermost layer. So retina is not separating from the choroid, neither it is separating from the vitreous. Actually, there is a separation of NSR from RPE itself. The moment you have collection of fluid here, suppose if there is a fluid collected, there will be a separation of these two layers itself. समझ में आया? So the word retinal detachment is basically a misnomer. Okay, this is our first topic in retina. What is retinal detachment? I hope everybody have understood. The word detachment, why it is a misnomer? Because it is a separation of retina within itself. It is a misnomer. Basically, it is a separation of NSR, neurosensory retina, separation of neurosensory retina from RPE with collection of fluid in the space between them. So if you have collection of fluid in the space between them, you will call this retinal detachment. Guys, you can make the diagram also, the simple diagram, so that you don't forget it. You can please draw the diagram also. Blood flow slide देखना है? Okay, I'll just show you, wait. So if at all there is a collection of fluid, there will be a detachment. Okay, now there are three mechanisms how the fluid can get collected. Three mechanisms. तीन तरीके से यहाँ fluid आ सकता है, and these are the different type of detachments. Okay, now I'm going to show you the blood flow वाला diagram once. Again, it is behaving abnormally. Okay. All right. Chalo guys. So there are three types of detachments. The first mechanism is the Rhegmatogenous retinal detachment, RRD. Rhegmatogenous retinal detachment, RRD. ठीक है? Rhegma. Now this is the first type of detachment, guys, and the word rhegma actually means a tear. Rhegma means a tear. Now first let me explain and then I'll give you time to write. पहले मुझे एक बार समझाने दो आपको. देखिए सभी लोग. There are conditions, especially when you have a myopia or when you have a trauma to the eye or when you have surgery in the eye. There are conditions when you develop a full tear in the neurosensory retina. If a tear develops in a neurosensory retina, what will happen? Do you remember vitreous is here? Vitreous is a fluid which will come here, here and come here. So through the tear, the vitreous will come and gets accumulated in the space. Have you understood what is happening? We wanted a fluid here. यहाँ से fluid कैसे आया? Tear बन गया. छेद कहाँ बना? NSR में. ठीक है? Especially these things occur when you have a myopia, trauma to the eye, or any surgery to the eye. Okay, now please write down. So it is the vitreous which is getting collected as a fluid within the layers of the retina. Am I clear, guys? The word rhegma means a tear. To understand the next one, it is not a vitreous hemorrhage, beta. This is not a blood. It's a fluid. Acha, vitreous humor. This one is vitreous humor. This one is vitreous humor. Okay, this is a vitreous humor. Yes. This is a fluid vitreous which is coming and getting accumulated in the layers of the retina like that. Okay. Now to understand the second mechanism of detachment, the tractional detachment, Let us see and understand the most important flow chart of the retina. Okay, let us understand and draw the most important chart. Now, all of you pay attention, don't write, first understand. So, most of the pathologies in retina starts from inflammation of the retina. This is an inflammation which eventually leads to ischemia and hypoxia. So, hypoxia is the most important thing. Suppose you get hypoxia in the retina, retina takes a revenge. It releases something from itself, and that something is VEGF. What is VEGF? Vascular endothelial growth factor. So retina will release VEGF from itself. Okay? Now when you have VEGF, 30 seconds. Okay, we'll just sum up this. ये बाद में पढ़ते हैं. After lunch we'll do 35 minutes is okay. The lunch break. All right. 35 minutes is okay for the lunch break. Okay. We'll start after 35 minutes. You can write down this if it is available. ठीक है? चलो. Bye bye.